My name is Dr. Suleiman Hussein. I'm a colorectal surgeon from Soba University Hospital, Faculty of Medicine, University of Khartoum. I'm very pleased today to introduce Mr. Krishnamurthy for this session. He's a consultant GIT surgeon from Chennai, from India. And actually, I'm very pleased. It is just coincidence that 2 years back, participating in the Train the Trainer course organized by the WGO. And that was a very good experience. And I like the city and I like the setup, and it was a very good experience. So my salam to all of those in Chennai. The session of today is a very important session for us as the GIT surgeon, which is anastomotic breakdown, anastomatic leak, which is usually sad news for everybody, for the surgeon, for the patient, as well as for the health system, where it put high expenses on the management, and patient should be discharged in a week time, may stay in hospital for 3-4 weeks, putting more expenses on the patient and on the setup. So it is a very important topic. I am sure that today we're going to have highlight on different aspects of management of anastomatic leak. We are very pleased to have you with us, the Sudanese Surgical Club today. I am sure it will be a very interesting session, and I'm sure it will raise more questions. And I'm sure that by the end of the day, we will have very strong messages to take home, or to take it to our theaters, or to take it to our patients. Now the floor is for you. Thank you very much.
Thank you, sir, for those kind words. I hope you are also doing fine there. And as you had rightly put forth, anastomotic leak is never a good news for any one of us. And I think today, Mr. Abbas has put me in a tight spot by giving such a, I would say, a good topic which needs to be discussed in detail. So I've just put forth few points. I'll not be going into detail into any one of them, but I think after the presentation part, there will be a lot of discussion and interesting queries that will be taken up, because it's a very practical problem that we are likely to face in our day-to-day life. So I just request Professor Suleiman as well as the other participants to feel free, and we should be able to gain more by discussion rather than just the presentations. If it's okay, shall I start my presentations?
Yeah. Yes, for sure.
So today we'll be discussing the anastomotic leak following colorectal surgery. But I have tried to confine more towards the colorectal anastomosis rather than the colocolic anastomosis. Because since colocolic anastomosis will almost follow the same pattern as and small bowel leak as well, and because it's an intraperitoneal anastomosis in majority of the cases. So I'll be dwelling more on colorectal anastomotic leak rather than colocolic anastomotic leak. So this will be the broad outline of our discussion today. First, the introduction, followed by definition of an anastomotic leak or a dehiscence, the various clinical presentations with which these patients can present to us with, the diagnosis and management of anastomotic leaks, and finally a few take-home messages. So the overall incidence of colorectal anastomotic leak varies widely. Some reports state as low as 1%, some reports state as high as nearly 1/4 of the patients who undergo surgery. This is primarily due to the differences in defining an anastomotic leak. Certain studies keep clinically evident anastomotic leak as the criteria for anastomotic dehiscence, whereas certain others believe radiographic evidence as a proof for anastomotic leak, which will be coming through our discussion as to why this has happened and how it is changing our interpretation of anastomotic leak. So as rightly put forth by Professor Suleiman, that it leads to mental trauma as well as, apart from the physical, social and economical problems associated with it, the lot of mental issues, also psychological issues are associated with such a leak. It leads to reoperations, radiological interventions, and sometimes even permanent stoma. In a patient whom we actually thought that patient might get away with a temporary stoma, if not no stoma, now patient has to be with a stoma throughout their life. It also has got a significant mortality rate, especially if it is diagnosed delayed. There is considerable variation in the definition of anastomotic leak, thereby leading to the varying incidences that have been reported. But again, the average should be around 10%. That is quite high, given that we are talking about nearly 1 out of 10 patients that we are operating is likely to have a leak, either clinical or radiological. So apart from the immediate postoperative problems that includes significant morbidity and if not mortality, there are also significant long-term issues associated with anastomotic leak. These are of two folds. One is the lack of physiological function of the neorectum that is being formed. Collection in the pelvis is likely to cause recurrent fibrosis, inflammation, and thereby reduce the capacitance of the neorectum. So this leads to a poor functional outcome in the long run. Apart from this, when the resection and anastomosis has been performed for a malignant etiology, we are also looking at reduced overall survival as well as increased recurrence locally. So why do they occur? They can be as a result of the spillage of the tumorous cells. There can be an immunosuppression that is associated with the sepsis that is occurring in the immediate postoperative period. This can lead to flare-up of the tumor cells migrating and then causing early recurrence. But I also believe a significant component is due to the delay in the initiation of adjuvant chemotherapy, which is proven. 4-week delay in the initiation of an adjuvant chemotherapy has been shown to reduce the 3-year survival and a 5-year survival by nearly 17%. So that is another reason why these people can have increased recurrence both locally, and there's a slight increased recurrence even systemically. So this is a meta-analysis which has dealt about this specific aspect of the anastomotic leak. So we can find that there is an increased overall recurrence, a local recurrence when it comes to patients who have an anastomotic leak. When it comes to systemic leak, that is the systemic recurrence, there is an increased tendency. However, it is not statistically significant. At the same time, it also affects the overall survival. So given this short-term and long-term impact of anastomotic leak, it is something that we should be aware of. But the problem starts with the first point itself. How do we define an anastomotic leak? So if we go through the literature, we have numerous terms, like even now, when the introduction was made, Professor Suleiman termed it as anastomotic breakdown. So even during my few slides, initial slides, I termed it as leak, then sometimes I told it as dehiscence. So we can find the list of terms that have been used interchangeably in defining the same pathology. Leak, breakdown, insufficiency, dehiscence, suture line disruption, security. So radiological leak, early leak, delayed leak. So what has happened over years is we have not been able to exactly define it as well as use the appropriate term. This has resulted in an inability to standardize various studies that can help us in preventing as well as in management of these anastomotic leak. So again, a systematic review that was conducted, I think in 2015, we can find the number of tests that has been used to define a leak. Majority of them have used in water-soluble contrast, what is mentioned as WS contrast. That is a water-soluble contrast. We can also find some have used barium contrast, some have used CT, and again the timing. So what we start with surgery, sometimes we even do an intraoperative uh, assessment of the anastomosis by means of air leak test. Some people inject methylene blue to find out if there is an leak. But coming to the postoperative period, again, there is a routine assessment in some one school of thought believes that the routine assessment should be done at the end of 4th day or 5th day. Some believe it should be done at 7th day. So again, there is so many variations in these definitions that we are not able to standardize our anastomotic leak for some period till 2012. I think this is something similar to the lines of postoperative pancreatic fistula that was defined in 2007. And this was proposed by the International Study Group of Rectal Surgery, rectal cancer. At present, this is the definition that is being quoted by any of the literatures that we are looking at. So the definition as such is defect of the intestinal wall integrity at the colorectal or coloanal anastomotic site, including suture or staple lines of neorectal reservoirs, leading to a communication between the intraluminal and extraluminal compartments. Moreover, the definition also includes a pelvic abscess, which is close to the anastomosis, as to be considered as an anastomotic leakage. So I think with this definition, it gives us more clarity in defining an anastomotic leak, and also it helps us in discussing it in forum and standardizing various protocols. This definition does not include whether it is clinical, whether it is water soluble contrast that needs to be given, whether an endoscopy should be done to this. So by any means, if you are able to demonstrate a defect and there is a communication between intraluminal and extraluminal compartments, then it becomes an anastomotic leak. So what are the factors that we are looking which can affect the outcome of anastomotic leak? I have listed just few factors, and we'll be discussing few in detail. So coming to certain preoperative factors, some comorbidities like anemia and hyperglycemia have been shown to have an increased trend. Hyperglycemia is still equivocal, but anemia, yes, if a patient less than 7 is likely to have an increased risk of anastomotic leak. Again, radiotherapy, which was initially thought to be an a significant risk factor in anastomotic leak. In recent years, somehow there has been a equivocal incidence of anastomotic leak with or without radiation. Yes, when compared to long course radiation versus short course radiation, the long course radiation has a decreased risk of anastomotic leak when compared to short course. But overall, if it is radiation versus no radiation, in contrast to earlier studies, those studies probably before 2012, which showed an increased trend of anastomotic leak in those patients who received radiation. The recent studies, however, have not demonstrated this result. They have not reproduced this. So coming to the intraoperative factors that might be related, it is similar to any other bowel anastomosis. So ensuring good vascularity is very, very important. Ensuring that there is no tension at the level of anastomosis is important. However, the tension which we talk, say in the case of a small intestine, we are unlikely to encounter any tension at the site of anastomosis. But we are looking at a patient who is going to undergo a proctectomy, and we are bringing a mid-sigmoid or a sigmoid colon to the nearly an anal canal for a colon anastomosis. You require a lot of mobilization. Again, there has been a variation. Certain people believe that splenic flexure has to be routinely mobilized. Certain people don't believe it. That they attribute, say, for there have been studies which show Asians have a more long redundant sigmoid, so that probably results in there's no requisite to mobilize the splenic flexure on a routine basis. But whatever it is, at the time of anastomosis, as surgeons, we should be comfortable and ensure that there is no tension at the site of anastomosis. So if it requires splenic flexure mobilization, it has to be done. The other few things which we routinely do is to ligate, high ligation of IMA, where we go up to the inferior border of pancreas to ligate the IMV and the root of almost iota for the IMA. So these are increase our length in colon mobilization. Coming to the suturing techniques, again, there have been so many studies starting in, I think, 1920s itself. They started with the type of suture that needs to be used. They also try to assess what should be the suture width from the cut end, what should be the inter-suture distance. So there is no hard evidence for us to say that this is how we need to do to prevent leak. But over a period of years, as with any other part of GI tract, now we are comfortable with a single layer continuous anastomosis is more than sufficient for a colorectal. Some people still believe that we need to do interrupted in colorectal. So whether we need to do through and through or an seromuscular inverting suture, again, studies have not shown any difference. So there is no single individual suturing technique that has been shown to be superior on a consistent basis. Similarly with the staplers, I assume that most of us are following the double stapler technique when it comes to low anterior resection, especially in a minimally invasive surgery setting. So where we divide this rectum distally with the help of a stapler, and the bowel continuity is established by means of a circular stapler inserted from the anal canal. The type of stapler, 2 rows, 3 rows, the size of the stapler that is being used, either it is a 28 mm, be it a 31 mm, be it a 33 mm. Again, they have not been shown to have a significant impact on the rates of anastomotic leak. Yes, a smaller stapler is likely to lead to an anastomotic stricture later on, but not an anastomotic leak in the early setting. There have been other devices where we just compression devices that have been used. I don't have any personal experience of these devices, but yes, few studies have shown some decreased leak rates, but generally there is no significant difference. Apart from this, other general conditions such as to avoid hypoxia, and intraoperative and an immediate postoperative inotropic support, vasopressor support is likely to have an increased leak rate. With the ERAS protocol and better understanding of the physiology, now the trend has been towards to lesser fluid during the intraoperative period rather than giving high IV fluids. This is likely to lead to bowel edema and thereby an increased likelihood of a leak. There are also few factors which have been shown in the postoperative setting that can cause increased anastomotic. So as I said, few studies I just wanted to highlight to show factors how they have changed. So this is a study which was primarily done to understand the effect of radiotherapy in patients with rectal CA. We can find that the leak rate is not significant in those patients who had preoperative versus postoperative. It was more or less similar. This is an interesting article which I came across, wherein I wanted to highlight how, as a surgeon, we should be prepared when we take up low anterior resection patients. Though, say, even I am used to a double stapling technique, and it's not rare for me to find difficulty in stapling the distal end. It might be, apart from the dissection part, the difficulty in inserting an endo-GA, especially when I'm doing a laparoscopic, is quite common, especially in a male patient who had a bulky tumor before chemoradiotherapy. In contrast to a routine single endo-GA stapler that is being used, sometimes the pelvis doesn't allow us to use the endo-GA comfortably. So we might end up using 2 or 3 also cartridges to just divide the distal stump. That basically means our distal stapler line is not going to be straight. It is going to be in the form of a V. So we are going to enter one side, then we are going to go horizontal, then we are going to go again with an angle. So all these are against the conventional principle to have a straight stapler line. So this is a study which showed that a preoperative CT And the pelvic anthropometry can actually help us in determining whether there will be a difficulty in firing a stapler. So they took interspinous distance, they took intertuberous distance, they took the measurement of pelvic inlet, pelvic outlet, and the sacral length. So what they found that they kept the criteria as requirement of 3 stapler cartridges. They found that if there is an decreased pelvic inlet, it shows the possible increased requirement of staples. Similarly, we can find the other tumor size, height. They are not so statistically different when it compares to easy stapling versus difficult stapling. The only factor that was noted in this study was the pelvic inlet, and we do know male patients will have an reduced pelvic inlet, and thereby actually these patients are more susceptible, makes life difficult in stapling. That's again probably a confounding factor in the gender part. So they try to assess the probability. With the multivariate analysis outcome, they try to predict the probability of using more than 3 staples, 3 or more staples. So those included gender, the height of the tumor from the anal verge, inlet, pelvic inlet diameter, interspinous distance, as well as the intertuberous distance. Apart from the preoperative setting, there have been now tools to assess the vascularity in the intraoperative setting. So the conventional 2 tools which we usually use are the laser Doppler flowmetry, and the second one in the lower photo panel is showing the ICG, indocyanine green fluorescent, which is then we use a near infrared camera to detect the perfusion. So they have their benefits. So especially if we are looking at patients who are having anal anastomosis, we are going to mobilize the colon a lot. We are worried whether the distal stump is going to have a good vascularity. Yes, the laser Doppler flowmetry as well as the ICG can help us to find out those segment which is ischemic when compared to the well perfused segment. We can find, see the mesenteric defect has been created somewhere here, and the ICG is almost mimicking the area of perfusion proximal to the mesenteric defect, and the one which is distal is showing ischemia. Whereas in the plain side, we may not be able to make out the difference. So whether it is foolproof, no. Because what happens is this ICG or laser Doppler flowmetry, we try to do before the stage of anastomosis. At the time of anastomosis, there are some more changes that are being added on. One, the colon might be stretched little further. 2, we are going to apply stapler. How much of the bowel which is going to be involved in the stapler, we don't know. This is more so if someone tries to change the configuration of the colorectal anastomosis. For example, if we are performing end-to-end, that is different from a person who is performing in side-to-end. So side-to-end, the colon has to be mobilized little further. In end-to-end, I expect this part of the colon to be involved in the anastomotic line. So if the ICG is going to be showing perfusion up to here, then I'm almost at the watershed area. Whereas if I'm going to perform a side-to-end anastomosis, I'm going to be well away from the cut end of this. So the likelihood of it being perfused is higher. So I think the morphology of the anastomosis is important. The lie of the colon when the assessment is done is important. So I think it is not a foolproof method, but yes, it is a useful tool. There are numerous studies on this account and they have shown some benefit, though they are not 100% foolproof. Coming to postoperative setting, there are 2 factors which I thought we can discuss today. One is the effect of oxygen administration in the immediate postoperative setting. This has been shown to have good benefit in gastrectomy patients. So there are, I could come across a clinical study also in this similar in colorectal, but however it was retracted. I think it was in 2011, published in Journal of Gastrointestinal Surgery, 2012, sorry, and then the paper was retracted for some reason. I couldn't find the reason as it. But on the other side, if there have been studies which show the pH changes that occur, we can find when the patient is administered 80% oxygen, the pH levels are more near normal. Whereas when there is 30% oxygen, they are likely to have a lower pH, that is a more acidotic environment, especially with only 30 minutes administration. So the longer the oxygen is administered, the more FiO2 of oxygen that is present, the lesser deviation from the normal pH occurs. This is something which has come big way with respect to the anastomotic leak. The NSAIDs which are routinely used in postoperative analgesia have shown to have increased incidence of anastomotic leak. So this is a recent meta-analysis which tried to identify no NSAID and use of NSAID. There is a significant increase in anastomotic leak. Only when RCTs were considered, yes, there is an increasing trend, though not statistically significant. Even among the NSAID, there is some variation. So diclofenac has shown an increased trend, whereas ketorolac, a significant increase, whereas ketorolac is only an increasing trend. So I think as we are operating patients who are already going to have an increased incidence, it is better to avoid NSAIDs in the post-operative setting. So can intraluminal devices prevent or reduce? There have been various, I would say, accessories which have been used to in the colorectal anastomosis to prevent leak. They start from a simple silicone tube which is having 2 flanges, and colo shield which will have a ring-like thing which is fixed to the submucosa of the proximal end, and there is a sleeve that goes down. We can also have the Murphy's button, which is similar to a compression device, and we can also have covered stent-like processes which can be placed intraoperative. There are other few things which were interesting, which can be passed transanally. So in case of a low rectal anastomosis, we can perform a transanal. This is almost similar to an endotracheal tube, which can help us in reducing the pressure in the neorectum, thereby reducing the tension on the anastomosis and prevent dehiscence. Similarly, there are also transanal tubes. So this is a good study which was published in British Journal of Surgery, which I think had nearly, this is group A and group B, which had nearly 400 patients. We can find that the leak rate is also is on the lower side, and the severity of the leak is also on the lower side. That is basically, the authors have described it as a silicone tube which has a diameter of 2 centimeters, which they insert it during the surgery, and then they cut it at the end of surgery. The distal end is cut here, and then this just place 2 sutures at the anal verge to prevent it from migrating. So there are some promising evidences with respect to transanal drainage. I, for one person, have seen surgeons who perform transanal drainages, but I routinely don't do it. I don't know, it comes with experience and their level of this thing, but I think it is something that we can still consider. So given all these factors that we have discussed, pre-operative, intraoperative, and as well as post-operative, there are recent trends towards predicting the risk of anastomotic leak when we perform a left-sided colorectal anastomosis. So this was the first one that was published in 2011 by Decker et al. So they analyzed retrospectively all their patients, and they tried to put forth various factors that can be responsible for the anastomotic leak, starting from age, gender, the performance status, BMI, whether the patient had previous history of smoking, neoadjuvant chemotherapy or radiotherapy, whether it was an emergency surgery, the distance from the anastomosis, and blood loss, and other factors. So this is the classical CLS, that is the colon leakage score. It goes up to a maximum of 43. So what it has helped is, over a period of time, people have started using it. to find out those patients who are at high risk. So for patients who are at high risk, the tendency of the surgeon is to form a stoma so that the clinical severity of leak is reduced. For those people who have a very low risk, stoma can be avoided. So that is how this has slightly modified our outlook in performing surgery. But I would like to highlight here that this is a graph from the same study. We can find the y-axis has the clinical colon leak score, and this is the continuous patients. The black dots are the ones which are had an anastomotic leak. We can find there are 2 black dots even when the CLS was less than 10. CLS less than 10 is less than 5 is considered very low risk. So some studies scored the CLS less than 10 is low risk. So again, it is not a foolproof method for us to predict an anastomotic leak in patients. So it's not mandatory that patients who have a low risk score do not leak. So again, we again start at the same point. Over years, despite so many studies, despite us varying our techniques so much, despite our understanding of pathophysiology really well, even at micro histological levels, still the trend of anastomotic leak hasn't changed much. We can see it is still hovering around 6 to 10% over the last 3 decades. So I think we are still far away from solving this issue. And where are we going wrong? I think few insights like recent interest in the colonic bacteria that can be playing a role in increasing anastomotic dehiscence. So this is not a new concept. This has been developed as early as 1954, wherein they started demonstrating, despite a devascularized segment in rats. So a 5 centimeter bowel was devascularized, and the anastomosis was performed. In few rats, dogs, they gave the penicillin to treat the intraluminal bacteria. The other group didn't have. They found an increased leak in those dogs who didn't have the antibiotic. Again, similar. This is a study that was published in 1984. We can find even among enteral and parenteral, there's a difference. So those rats which received an enteral nutrition, namely neomycin and erythromycin, they didn't have any leaks, whereas those who received parenteral still had leaks. So basically trying to say the leaks can be due to, again, there is no hard evidence in humans as such, but leaks can be due to the variation in the intraluminal microbes. So Enterococcus is supposedly increasing at the end of surgery. So when a patient is actually injected with a bacteria in the cecum, this is a rat study again, which is where they try to inject bacteria into the cecum at the time of surgery. They did the anastomosis. So they had 4 groups. The 2 factors that they studied was radiotherapy to the area and injection of the Pseudomonas organism. And we can find that the second, which had only the Pseudomonas, had a slightly increased rate of leak rate. Again, radiotherapy again had a slightly increased when compared to no Pseudomonas and no radiotherapy. However, when both were combined, it led to a leak rate as high as 80%. So again, trying to emphasize that there is a possibility that the radiation killed the in-house bacteria, and the Pseudomonas actually worsened the microbiota equilibrium, and thereby causing an increased incidence of leak rate. I think this is something we need to still study more and probably put it into clinical relevance. So there have been trends where they had started using an local antibiotic contamination, which included ciprofloxacin, metronidazole, and they did find a decrease in the leak rates. That is 5% when there was a decontamination that was given, whereas compared to placebo, which was high as 20%. So coming to the diagnosis of anastomotic leak, one should be aware that a colorectal anastomotic leak doesn't mean they occur within 3 days or 4 days. This is a graph from study in Annals of Surgery, which actually studied all anastomosis, starting from ileocolic, colocolic, and colorectal. There have been incidences where you can have even a delayed colorectal leak. It might be possible that the leak occurred little earlier, but clinically manifested little late. But yes, as a clinician, as a surgeon, when we perform a colorectal anastomosis, we should always be aware that a delayed leak is a possibility, and never turn away a patient saying it is nothing, not to worry if it's above 7 days. So any complaint from a patient which can actually be an initial marker of a colorectal leak should create suspicion and probably proper evaluation to avoid disastrous complication. So it's primarily a clinical suspicion. All other investigation actually complements them. For example, inflammatory markers. Simple leukocytosis can be treated as post-surgical, but nowadays we have moved towards the trend of using CRP, C-reactive protein, to predict colorectal leak. And we can also have an imaging. For example, in cross-sectional imaging, CT can help us to find an intraperitoneal or an extraperitoneal collection. What is the vascularity of the bowel that is involved in the anastomosis, whether it is having ischemia with an IV contrast is given. And then definitive evidence can always be given when there is a contrast extravasation that is present following rectal contrast. So this is a meta-analysis of patients who had C-reactive protein to predict colorectal leak. There were 5 studies which performed it on POD3. There were other 5 studies which are performed on PO4, and 3 studies which performed it on POD5. We can find when it's negative, they have very good predictive value. However, it doesn't rule out, and when it's positive, it doesn't actually concur with an anastomotic leak. Again, to say, the accuracy is still questionable. We should always have a clinical suspicion, and the CRP can help us further, but it cannot be the sole determining factor for diagnosing anastomotic leak. So how does the CT present to us? The CT can be in the form of a presacral abscess here, which is nicely seen, and then this is after some time where the sacral abscess is resolved and the continuity is maintained. There is no rectal contrast. This is an image which I took from internet, from an article, which showed an active contrast extravasation, which is flooding through the peritoneal cavity, almost reaching up to the anterior abdominal wall from the colic anastomosis. Again, this is something classical we see on the 3rd day or 4th day. We'll have the staple line, and we have multiple pneumoperitoneums, pockets. We are worried whether it is secondary to the surgery or whether it is a true anastomotic dehiscence. Whenever we have a pocket of air which is adjacent to a stapler line, it is better to assume it is an anastomotic leak rather than wait and watch. So patients with colonic leak who then go into colonic sepsis are less likely to give us time. And especially if these patients are having other comorbidities, who are malignant patients, who had poor nutrition status. So those subgroup of patients don't give us adequate time to act. So an early clinical suspicion with even a slight evidence of anastomotic leak will require intervention rather than wait and watch. So this was one algorithm which I found in an article where they try to mention CT with and rectal contrast. So if there is an rectal contrast, there is no doubt. Extravasation, there is no doubt. It is a confirmed anastomotic leak. However, see, we can clearly find even if there is no extravasation, the AL ruled out is unlikely. Without RCE, it is very difficult. It goes into uncertain and other things. Even with this algorithm, there was another study which they found that the negative predictive value is nearly 70% only. It doesn't go up to 100%, which we ideally want it to be. So 19 patients who had actually an anastomotic leak had a negative CT. So they use the findings such as peri-anastomotic collection, peri-anastomotic air pocket, and intraperitoneal air pocket. All these were signs that were taken as a predictor of anastomotic leak. Despite taking all those signs as positive, uh, still 19 patients who had an anastomotic leak didn't show CT finding. How do we manage anastomotic leak? So I thought I can start with the grading that was proposed by the International Study Group of Rectal Cancer. A patient who is having good clinical condition, who has no clinical symptom, and probably has a mild turbulent fluid or even a serous fluid from the drain, radiological evidence shows a small contained leak, probably do not require any kind of treatment. This is a group of population we are likely to encounter. But again, we should be sure that the patient fits in with all of these criteria. Even if there is one criteria which is going to be away from this set of criteria, it is better to intervene rather than wait and watch. So coming to the grade B, that is those group of population who require some kind of intervention, not the uh, surgical exploration, are those patients who had mild symptoms like an abdominal pain, can have a fever, can have purulent discharge via the rectum or via the vagina, can have evidence of inflammatory markers increased. So these patients can be attempted to have, but are however clinical condition is well preserved. So this becomes very, very important. Any patient who has an severely impaired clinical presentation, clinical condition, should immediately be aggressively managed rather than doing conservative managements in the form of antibiotics and percutaneous drainage. So when we have a good, well-preserved patient with mild symptoms and there is evidence of anastomotic leak, we can try antibiotics and then percutaneous drainage. Even a transanal drainage can be attempted. However, in the presence of either florid peritonitis or in the presence of a poor general condition, it is better to take the patient up for surgical intervention. This is the Inchase classification for diverticulitis, but I thought it is a good way to actually address the problem of an colorectal anastomotic leak. So this is the type 1 where we have a pericolic abscess. The type 2 we have a localized abscess. The type 3 we have an disseminated diffuse purulent contamination, and the type 4 where we have the diffuse fecal contamination. So probably we are looking at patients in the grade C, that is these groups are likely to have the 3 and 4. The 2 classification, that is those patients who had a large loculated collection, may have be in grade C or maybe in grade B. The grade 1 are likely to be either grade A and B rather than the grade C. So how do we manage? So whenever we are dealing with an diffuse contamination, where the regular surgical principles, we'll have to drain the intra-abdominal collections. We'll have to do the source control, which can be either in the form of a diversion or a repair if it's feasible. Sometimes we might have to resect the segment of colon that is involved in the anastomosis as a result of ischemia, necrosis. And sometimes we might have a very large dehiscence which is not amenable for an repair. So given this principles of surgery that we follow, whether is it fine to do diversion and then a lavage, or is it mandatory to do a resection and something like an Hartmann's? So this is the good study which was conducted in nearly 90 patients, where they had tried to find out what is the outcome in patients who had a salvage, that is those patients who underwent laparotomy, but the anastomosis was not taken down. A lavage was given and a proximal diversion was done. The other group of patients are those who had the anastomosis that was taken down and the proximal end of colon was brought as an end stoma. So comparing these two groups, we can find that both groups can be, that both types of management can be performed. in the extraperitoneal low rectal anastomosis group as well. And the outcomes, we can find that the dehiscence, the intraperitoneal hemorrhage, the reoperation rate, the progressive septic shock, all these were comparable between the two groups. That is to say, those patients who were just a lavage and a proximal diversion had similar outcomes to those patients who had their anastomosis taken down and then proximal stoma performed. Remember, those patients who had the anastomosis taken down and the stoma matured might actually have it as their permanent stoma. Reversing this stoma is likely to be difficult. We'll have the pelvic sepsis, which is already settled in. These patients are likely to have defaulted in their chemotherapy because of the requirement of surgery and grade C anastomotic leak. So what we are looking at is, apart from the immediate postoperative period, a patient who is having the anastomosis taken down is likely to have a poor quality of life even in the long term. So again, the table showing the same concept. So coming to the type 1 and 2, that is those who had a pericolic collection or who had a contained collection, we can attempt lesser invasive measures, like in perianally. If we are able to palpate the defect, we can place a drain, either a Foley's or a Malicot. Sometimes we can even place a percutaneous drain to drain these collections. There is an issue with percutaneous. The problem is we may not be able to have an access from the anterior side. So sometimes we might have to place it from the gluteal side to drain these collections because of the pelvis collection, which are located a little lower down. And whenever we are going through gluteal, there is always a risk of sciatic nerve injury. So that is something that we'll need to be aware of. In case of an extraperitoneal leak, sometimes simple drainage by the anal canal through the anal canal can be associated, complemented with the diversion as well. So that is 50-50, but still that can be added to an perianal drainage. Nowadays, we are also having the endotherapies that can be used to heal these type 1 and 2, not the type 3 and 4. So this is an study which showed a use of VAC in leaking and anastomotic leaks. We can find the tract which is seen here. A VAC was applied over a period of 2 weeks. The tract has actually closed. This was also accompanied by an proximal diversion. This is again another study which showed about the usage of VAC in anastomotic leak healing. So there has also been studies which showed we can use an endoscopic clip to close these rents. We can combine an endotherapy with an percutaneous drainage. So this is how a collection in the percutaneous drainage is taken care of by means of an interventional radiologist approach, and the further contamination, that is a source control, being taken care by means of placement of stent. Some people have even tried to close the rent by means of a perianal single, like almost like a TAMIS, where they insert a single port and try to close the rent. So this is a rough flow chart which I thought can be used and which can be taken forward as a message from this discussion. Whenever there is clinical signs of anastomotic leak, so again, the starting point should be the clinical suspicion. We can try to perform an endoscopy and CT or a rental contrast enema. Any of them shows which is going to confirm our suspicion. In case of a small anastomotic leak without peritonitis or sepsis, we can try to just address the collection with an ultrasound guided or a CT guided transcutaneous drainage. In case if this can be, this require further, the distance is quite large, but less than 50%, we can complement these drainages with an endoscopic lavage and other endotherapies. However, in case it's going to be large dehiscence and or severe sepsis and or generalized peritonitis, it is better for the patient to undergo surgery, and it will be in the form of exploration and lavage. It can be again followed by ileostomy, colostomy, or a Hartmann's procedure, or sometimes even converting an low anterior resection into an abdominoperineal resection. In the chronic setting, these leaks can form nice walled off cavities which can persist as sinuses. It is not uncommon that when we see patients who want a reversal of the protective ileostomy or colostomy, during an perrectal examination, we'll find a small defect which has a sinus cavity which is going beyond the luminal component. If the sinus defect is going to be small, or if the cavity is going to be small, nothing needs to be done. However, in case if the cavity is going to be large, that needs to be addressed. So these are some techniques that have been used. Surgically, we can try to cut off this is the sinus cavity, which is going posterior, which is demonstrated by this pouchogram. And we can try to divide from the lumen and the sinus, divide the wall between these two so that we don't have a loculated fecal collection later on. Sometimes we can use this stapler for the same principle, dividing the wall. So coming to conclusion, it is a significant problem and it can have serious short and long-term consequences. We can classify patients based on their CLS score and the modified CLS score. So it helps us in counseling these patients. It helps us in identifying these patients who probably have high risk of leak and probably perform a stoma, protective stoma, to reduce the incidence of clinical leak. However, coming to the management of these leaks, clinical suspicion is the most important point that has to be emphasized. And early appropriate intervention is crucial, and each presentation is different. So probably the one which like something like an Hinchey classification, we can try to tailor it, tailor the management based on the kind of presentation their patients are having. Thank you, sir. That is my email ID. So if any queries later on, we can discuss. Professor Suleiman, sir.
Thank you very much, Dr. Gautham. Actually, as I expected, very brilliant. And I think talk for a very difficult topic. And thank you very much for emphasizing very practical and already slots. And predict leaking anastomosis or broken down anastomosis pre-operative. And you have this when you come to patient pre-operative management. And I think, thank you very much for emphasizing this role. I think that you cannot operate on somebody with an albumin of 3, hemoglobin of 8, somebody who has been on steroids. And so this is, have to be very careful about it. And this is a very good message for our younger colleagues. And intraoperatively, in our experience, we are doing a lot of ultra-low colonic, anal, colorectal anastomosis, and most of the time we don't do. Important is to avoid tension, and I think that tension will compromise the vascularity. And there is no right or wrong. You cannot say I do not put down the splenic flexion. It depends, as you rightly said, whether whatever you're going to do, whether you want to do the to bring the splenic flexure down or not, it depends comfortably without tension. And I think an experience about it, the presence or absence of pelvic drains, and have they anything to do with increasing the incidence of anastomatic breakdown. We do air leak test as a routine. And most of the time, we may detect air bubbling. And you just you put a stitch over it, even if it is a stable anastomosis. So it is a very simple procedure. You can do it intraoperatively, and it will help you to detect anastomosis very early intraoperative. And I think another important point in when you do, and I think you also want to ask your experience with, when you do a double stapling technique and the rings are complete, is fair enough. You do an early test, it is negative. But if the ring is partial or incomplete with few millimeters or so, and in spite of the fact that we do a leak test, you find that it is a tight anastomosis. What would you do for such cases? Do you still prophylactic measure, or would you sleep happily, or just leaving it? And
Sir, that's a very good question, sir. I think at the end of the day, I think you mentioned it's as a surgeon, we should be able to sleep well. So even if there is going to be a slight doubt that the anastomosis is not proper, it is better to take corrective measures during the surgery. The best way to prevent complication best place is in the OT rather than the postoperative one. So if in case if I find the stapler has been performed well, the donuts are intact, but there is some air in the air leak test which we perform, probably take some reinforcing sutures and perform a diversion stoma. In case I have any doubt with the stapling device, it might be an stapler that has got stuck, or if the firing was not done properly, if the donuts are not intact, it is better to assess the anastomosis completely and try to take sutures wherever we are having doubt, rather than just performing a stoma and coming out. Again, performing a stoma doesn't prevent leak. It can probably reduce the severity of leak, but it still can cause disastrous complication in post-operative setting. So we should not
Thank you very much, Professor. Yeah. I think this is a very important message. The stoma is not an alternative to, if you are not happy about that. If you are not happy about the anastomosis, the answer is not to defunction. The answer is to make it right. And if you have gotten a suspicion about the integrity you have, even if sometimes we undo the anastomosis completely, and rather than to sit on leaking anastomosis to present 3 or 4 days later. So thank you very much. If you are not happy about anastomosis, don't get away with the stoma. I think the answer is to fluid type, tension-free, blood vascularity, good blood supply, and still that you hope, and then after that you hope for the best. Another point I think that in the postoperative period, thank you very much to emphasize the importance of clinical evaluation. And I think that the patient who doesn't look well on the second or third postoperative day, you have to be very careful. This is not a hidden leaked anastomosis. If somebody is having a bit of tachycardia, he doesn't look well. I think any patient with an intact anastomosis in the second, third postoperative day, he should be tolerating some good amount of fluids. It should be afebrile, pulse is normal. But if the patient is having a bit of a spikes, and in spite of the absence of abdominal signs, just a temperature, he doesn't look well when you look at him. This is a high index of suspicion of a leaked anastomosis. It doesn't cost you much to inject a water-soluble contrast to make sure the anastomosis is intact. Don't put that to chest infection, atelectasis, malaria, or so. And I think that most likely patient unwell after colorectal anastomosis, what I'm telling my registrar, that most likely this is a leaking anastomosis, still prove otherwise. Postoperatively, I thank you very much for emphasizing the role of hypoxia. And now we keep those patients on that about internal hypoxia on those patients, because of the effects of narcotics, effects of, and most of the time they have some degree of hypoxia, deprived oxygen supply to the anastomosis. So we usually stress the importance of nocturnal oxygen for those patients, in particular in the first postoperative day. Another important practical point, I think that, thank you very much for emphasizing it, is intravenous fluids. And also my question here about the role of rapid enhanced recovery programs, where those patients are weaned early from intravenous fluids and they are started oral fluids. And I think this most likely data will be coming, that this will have an influence of the incidence of leaking anastomosis. Thank you very much. This are just point to emphasize, and I think I am sure that there are many questions from the audience, and if there are any more comments.
Welcome, Mr.
Anybody want to ask, just raise your hand, and I think you can speak back.
Assalamu alaikum.
شكرا. السلام عليكم عمر. One of the senior colorectal surgeons, also he works in Sobel University Hospital, and he has got a very good experience on surgery in general. Welcome, Omar, and I'm sure that you have got many comments. We are looking to share your experience.
Yeah. Thank you, Dr. Gautham, and thank you, Suleiman, for this very important topic. And I think, Dr. Gautham, you really
Hello, Mr. Omar.
Presented very well. Hi.
Hello, Mr. Omar. There's interruption in your voice. Hello? Hello? Mr. Omar, we are not hearing you. I think we lose connection.
I think we lose connection. I think we can go for other comments and come back to Omar.
One of the doctor, he didn't write his name. You are welcome.
Hello? Can you hear me?
Yes.
Hello?
Mr. Nadir Hilal is a consultant colorectal surgeon from South Africa. You're highly welcome.
Good evening, everyone. Assalamu alaikum, Prof. Thank you for the very nice presentation. Just 3 or 4 comments about, so there's some controllable elements during the surgery that we can do to minimize the risk of anastomatic leaks. First, the blood loss. If the blood loss is more than 500 mils, and if the operative time is more than 4 hours, this also increases the risk of anastomatic leak. There's something that some elements that we can't control, like the preoperative chemoradiotherapy. So it's known that radiotherapy, preoperative radiotherapy, or neoadjuvant radiotherapy is the most common cause of anastomatic leak. So the other thing I'm wondering about is, my question is for the doctor. What about the use of ICG, which is now like a routine practice in most of the centers, in decreasing the risk of anastomatic leak? This number 1. And number 2, your experience with the endosponge, which is now also one of the most important things that used for the treatment of anastomatic leaks. Thank you.
So thank you for the kind words. Coming to the first question, role of ICG. I basically use it whenever I am going for an ultra low anterior resection or an coloanal anastomosis, because there I know that the vascularity is going to be an issue. In probably low anterior resection, I don't routinely perform it, but in ultra low, yes, I do routinely perform it. So what we generally do is we mobilize the entire colon up to the splenic flexure. We divide the IMV at the inferior border of pancreas, and once we go down and do the division, because when you are planning for coloanal anastomosis, sometimes we'll divide it down from the anal side, an intrasphincteric resection or an ultra low. When we divide it, we bring the colon out, and then we inject the ICG. We have 45 seconds, 30 seconds and 45 seconds time. We'll then assess the perfusion at the end of 30 seconds and 45 seconds. And we identify the place where it's showing good vascularity, transect it there, and then perform the coloanal anastomosis. For the second question, I forgot. Endosponge, yeah. We had experiences 2 patients. And yes, they are very good. To be frank, the only discomfort is them having a tube which is coming out through the rectum. But I think it is going to be anyway present, even if you are going to present have an Foley's or a Malikots or even any drain which is placed transanally. The endosponge is going to, I think one patient had it for 5 days to 7 days. The other patient had it for another, again, 1 week. Definitely the healing was better, and moreover, in both the patients, when they came for the reversal of the protective stoma, there was no evidence of a stricture. I think what the endosponge did was it tried to reduce the fibrotic process which occurs outside the lumen. I think that was an important thing which happened and prevented anastomotic stricture, because invariably any patient who has a leak, generally they go for an anastomotic stricture, especially if it's a stapled anastomosis. So I think that is one more advantage. I've not seen an article or an scientific evidence for it, but from personal experience, I think it reduces the inflammation outside the anastomosis, thereby reducing the chance of stricture also.
Yeah, because got some experience with the endosponge, and there is a question of one of the colleagues about the leaking pouches after total rectocolectomy and alveolar pouch. It's also one of the a very good way of preventing or treating the anastomatic leaks. The Dutch group, I think, from the AMC have a very good experience with it. They are doing it regularly, so they can change every 4 or 5 days for 3 or 4 times. And some of them, they can do it in the endoscope suite, and they got a very good result. Because as we know that, especially in the anal pouches, if you treat them perfectly, then the outcome is very good. So when compared with patients who doesn't have leaks, I think that after 10 years, it's about 88%. So I think for alveolar pouches, especially alveolar pouches, endosponge is a very good way of treating leaks. Thank you.
One of the participants raised his hand. Mr. Omar, you are welcome for the second time. We don't hear from you this time. You are welcome.
I don't know when the audio was disconnected, but did you hear my question?
No. You can start.
No, Omar.
Okay. I just mentioned 2 points. Very important topic. Thank you very much. Very important topic, and the evidence and the presentation was very, very, very interesting. The thing, as Suleiman and you mentioned before, that there is 2 important factors in this topic. One is to avoid having a leak from the start. And as you mentioned before, by good pre-operative, intraoperative, and post-operative management, you can do that. And the other thing is to have a very aggressive management if you recognize a leak. And you really elaborate very well on the management when that happens. In our experience here, we have two things, and I always mention it to our junior colleague, that one is attention. As Suleiman mentioned, you have to recognize that you don't have attention. This is very important. And the other thing is to do the leak test during the surgery. We have a few cases where we have a leak due to the stabilizing devices. And I think it's very important for everybody that when they do a very low anastomosis, to make sure that they have a very good brand for the anastomosis. That is very crucial, very crucial. A question, if you have a patient without a covering ileostomy or colostomy, and you have a small leak, type 1, would you just drain it, or would you, with the drain, do a covering colostomy or ileostomy? And again, thank you very much for this very, very elaborate presentation.
Thank you, sir. So thank you for the question. Sir, as I said, the first will be to drain the collection. There is no doubt regarding that. And I think if the patient is having a good performance status and the patient is not having a florid collection, the distance after assessment is small. So I think we can wait. In case any of these criteria is going to be like patient is not doing fine, patient has a large collection, patient has a large distance, if the CT shows an doubtful vascularity. So all these things warrant an surgical intervention. So at that time, definitely a proper stoma is better. I wouldn't jump, but the threshold for a stoma will be very low.
Excellent. I quite agree. Thank you very much.
We have few questions, sir.
Yes.
One of our colleague asking regarding ligation of IMA, high ligation or low ligation. What is the effect on the leak rate, on the rate of the leak?
So it doesn't have a bearing. The high ligation or low ligation, it doesn't have a bearing on the leak rate actually. Actually, high ligation helps in mobilizing the colon better. So if at all we are looking at an anastomosis which has the tension, we should be actually doing a high ligation rather than a low ligation.
Other question from Dr. Anis asking about for how long you can lift the silicone inside the bowel, and is it safe?
Okay, that study actually had it, I think, for 7 to 10 days. I'm not very sure, but I think they had it for 7 to 10 days, and they didn't report any complication following the silicone. It is very, as the authors have actually classically described, it's a very soft drain. Basically, it's trying to reduce the anal sphincter pressure rather than doing anything else. I think it is a combination of protecting the anastomosis as well as reducing the anal sphincter pressure that is actually offering the improved outcomes. They have not reported any complication with it. I don't have a personal experience with those drains. I have placed anal drains which are normal, our abdominal drains as well as the ET tubes. It was done by one of my seniors who used to do it routinely for an ultra low anterior resection, and the outcomes were good. There were no issues with the placement of drains or silicone.
Thank you very much, Dr. Gautham. And I think, as I expected, I think you answered most of the questions. And I think you emphasized the importance of how to avoid a leak first and how to diagnose it and how to manage it if it happens, because it is something which unfortunately is inevitable. Sometimes you cannot avoid it, and that is the very good session. And we hope that to see you more in other GIT topics in our surgical club. Thank you very much, Dr. Gautham, and thank you very much for the audience for their participation. Thank you.
Yeah, thank you.
Thank you, sir.